Thank you, everyone, for joining us tonight for the ISM Rochester membership meeting. I just want to do a nice welcome to all of our members joining us today and all of our guests and also our students that may be joining us and those from the University of Rochester. At this point, I would like to say, please, this is going to be an interactive discussion tonight. We would like you to use the chat or the Q&A. If you would like to ask your question or make a comment live, just raise your hand and then we'll press a button and you can then speak live to Tom tonight. At this point, I would like to turn the program over to our chapter president, Leanna Earlsall.
Although she just put in the chat that she can't hear us.
Okay, Leanna will be with us shortly. Just give us 1 second or two. Okay, she did get disconnected, but she will be. Well, Tom, I would like to introduce Tom for Leanna, who is going to be doing our presentation tonight. Of course, I don't have his bio in front of me right now. So Tom, if I can, if you would like to do like a little self-introduction of your background, and then we can get on with the presentation.
All right, I can do that as soon as let me just get my presentation up here.
Okay, thanks.
We'll start there. And we'll start here. And I'll start by getting my face out of the way. There we go. All right. Hi, everybody. Can you all see that okay? Kathy, can you see that?
Yes, we can. Looks great.
All right. So hi, all. I know many of us have crossed paths in the past in a different role than probably anything you remember. So Jim DC had asked to share some of the experiences we had here at the U of R Medicine over the last couple of years. And you got to watch it play out on the news pretty much every night. And we didn't exactly experience any of that, thankfully. But I'll walk you through what we did do. And I know we've got some participants here from the U of R as well. And maybe some of the secondary, tertiary questions you might ask, I'll bring some of them in to share what their experiences were, because there's a whole lot of activity that took on. And this is a really good example of everybody playing their own roles so that the whole succeeded. But I'll start with just a little background, because even if you're from here, other than the fact that you can't drive a block anymore without seeing one of our signs, let me just give you a little overview about what U of R Medicine is. And obviously that's an aerial view, and it grows and grows and grows. So these numbers are probably a little outdated. It goes back a few months, but get the gist. And on the university side, you see the number of students that we have here, but we are the largest employer now, 28 pushing 30,000 now, and one of the largest in New York State, between the university and the medical side. There's research, of course, there's School of Music, there's the Memorial Art Gallery. It's a real diverse collection of different things, some of which you've enjoyed, some of which you dread, but that's who we are. It kind of breaks down a little bit like this. Across University of Rochester, obviously you got all the different schools like I just mentioned. Maybe some of you attended here, many in the Simon School, for example. The U of R Medical Center here locally has the School of Nursing, School of Medicine, all tied into, and interacting with the university. But then when you get right into the university, U of R Medicine piece of it, what's key, if I start down the right-hand side, is the 6 hospitals. So Highland Hospital, right around the corner from us here. Noyes, which is in Dansville, New York. Thompson, which is in Canandaigua. St. James and Hornell, and Jones down in Wellsville. So kind of working ourselves south between here and the Pennsylvania border. And soon we'll be adding 2 more. And you'll see 2 like under Highland. Highland also considers a couple of senior living homes, Brighton, Pittsford, the Highlands Living Center. All of this plays into what happened here back in 2020. And you can see the various hospitals within Strong, what we call medical faculty, which is really the doctors and the dental. So all that plays in and shown a little bit more graphically here, pushing 1,500 licensed beds now. Here's some of the numbers in terms of how busy. And again, this is May of last year, so that considers a lot of the COVID activity. But just all that is just to give you some scale of what we're talking about in terms of who we support as a supply chain. So looking back, what I'm going to do is kind of take you back a few years to what we were pre-COVID, some of the transition that took place during it, and where we look to be going in the future, and all under the categories of people, process, and technology. So on a people side, very tactical. Most of the operations around here, we're kind of self-sustaining, siloed. And this isn't just about supply chain. This is just generally how the place behaved. Kind of like I mentioned earlier before we came on, just mentioned a story about the lack of investment in supply chain versus competing with operating rooms and surgery centers. Most of the folks here had been working in healthcare for quite some time, if not their whole career. And when I say a lack of career development, not really, mostly just how active we've been in terms of getting people cross-functional experiences and investment in training and that kind of thing. From a process standpoint, all the hospitals pretty much working independently. Plenty of mostly redundancies, different groups all performing the same functionality. Starting to learn lean, starting to focus on their work processes and trying to reduce and eliminate waste, but kind of in its infancy. And I guess maybe the biggest thing here is a real dependence on our distributor. Medline is our medical distributor, and our dependence was on them to come fill bins and show up 2-3 times a day. And we'll see how that played out. And from a technology standpoint, just a lot of systems. We've been acquiring hospitals, so not everybody on the same ERP system, no transparency between hospitals, and no real method for inventory management or reporting. And again, you'll see what that meant to us. So I sprinkle it in with some quotes that kind of set the tone for each page, and this one is pretty much about paying attention. So very early in 2020, we have a staff member here from the Beijing area, and we started getting wind of this coronavirus. And as much as we reacted to it or didn't react to it here in this country, we did start reacting to it, knowing that so many manufacturers that we had were in China, and specifically in the Wuhan province, and this was going to be an issue. A lot of us here, again, when I talk about the complementary skills, people who have been in the hospital and working here, and then bringing in folks with global manufacturing, global supply chain experience, those two things really complemented each other as we went. So, when I say an immediate assembly of cross-functional teams, that's what it was. we, the outsiders coming in with a lot of experience with global supply chain crises, asking the hospital subject matter experts, what do we need to be worrying about first? So that took place really quickly. There were some early comparisons to the Ebola outbreak in 2013, the last real big pandemic, and then you throw in SARS and a couple of other things that were that this group had experienced in the past. And they've done things. Our environmental health and safety and supply chain folks have put emergency stockpiles together and things like that. But again, the biggest bullet here is that immediately we heard from our medical distributor that their contract manufacturers were in China. And that was going to be a major difference. So the Ebola outbreak originated in, out of Africa. That didn't shut down any manufacturing. We was buying product from there. So this took on a whole new exponential level of concern. And that's where we were starting from back in January, February of 2020. This graph, there's no real data behind it. It's just to show you graphically what we face from a supply demand standpoint. So from a supply side, if we're sitting here in January 2020 getting 100% of what we needed, as that manufacturing capacity diminished and in customs and export requirements in China to maintain supply internally really started hurting us. And it worked itself down to they could only provide 30% of what we needed. And then our own government, both county, state, federal, started drawing from all the manufacturers to build up their stockpiles. So we were actually competing with FEMA and with other government agencies for the limited amount of supply that was available. At the same time, if you consider X to be what our demand was in January 2020, we'll now multiply it by, I don't know, 10X, pick a number, is just the surge of patients and the new safety requirements, like everybody here having to wear a mask, shields, gloves, gowns, all of that. And that's where you started seeing the scary newscasts from New York City and people wearing hefty bags or wearing a mask for an entire week. All those things that were really frightening to watch as all of our families learn for the first time what it is we do when we say we work in supply chain, but at the worst possible time. So we had a huge gap in terms of our supply demand, or our supply matching our demand. So again, I always love this. Everybody has a plan until they get punched in the mouth, right? So you think you have plans, you think you've got a stockpile, you think you're ready for the next big thing. But yeah, here we were. Our stockpile was 7 years old. It didn't smell very good, so nobody wanted to wear that mask. The elastic started breaking, and actually it took us quite a while to even find where it was. And again, like I said before, just like the reaction to Ebola, similar in some ways, but similar only on the demand side, not so much on the supply side. So because we had a medical distributor that reacted, or I'm sorry, that actually provided all our deliveries kind of a just-in-time sort of a way, we had very little safety stock on hand. And without an inventory system on hand, to tell you the truth, we barely even knew what we had on hand. So stock isn't centrally located. It wasn't managed. They were all unit by unit. And quite honestly, the biggest problem became the requirement to buy. You couldn't go out and buy 1,000 masks because you're a nursing home or gowns. You had to commit to 500,000. So that's when we had to immediately start acting like a system, kind of a hub and spoke type of a mentality. where we would buy centrally here, Strong Hospital would buy centrally, we would store it separately and let each of them buy from the central location. And as the only way they were ever going to survive. So before I move forward, that's all kind of setting the stage for where we were. Any thoughts or questions or clarifications? Because it really at this moment in the whole thing is about as nervous and anxious as you want to get as a supply chain professional. So anything else I can do to help you understand that?
Yeah, no questions yet.
All right. So moving on. So here we are, 2021. We're all getting on the job pandemic training and the urgency of the whole thing, right? Again, I'm going to assume that many of you on this call as supply chain professionals, most of you have worked in manufacturing environments or distribution environments. And the worst fear you have is shutting down a line and sacrificing revenue and being blamed for that. That's also very important and a real concern. But now what we're facing is the health and well-being of our staff, of our patients, of our families, of our communities, and just a little different sense of what urgent meant. But some of the good that came out of it, those silos were broken down, right? The collaboration and interdependence that had to come out between supply chain, purchasing, employee health, pharmacy, everybody willing to help in any way they could, right? The people who build prosthetics for amputees are now building masks. The pharmacy's making hand sanitizer, right? All these things, you've all been part of sunset meetings in a manufacturing environment. We have what we call the command center. And all those folks were reporting. The lab folks, we have Bailey Road here out behind our IT, who's doing all the COVID testing, all the data, all the numbers, trying to get everybody to understand everything. And everybody was chipping in to help out the supply chain. So process-wise, starting to work as one U of R system instead of the dozens or hundreds or even 1,000 individual sites that exist. Again, that hub and spoke mentality. Demand planning, trying to figure out what we were using up every day and projecting that outward to future needs. We're not working off an MRP system here that, in a bill of materials that projects based on what we're estimating as far as a build, what we're going to need. Same with spares. That didn't exist here. We had to create it. And then really building resiliency and alternatives to what was coming out of China. This is all coming out of China and unbelievably specifically to that Wuhan province. And then the technology piece. We had to create it. We were very reactive. There were short-term things that we had to build, and I'll show you some of that as we go forward. There was a driver to get a common ERP system across all the hospitals. Not that they didn't have one, they had different ones. Again, they were acquisitions that came in with their own. So there was no visibility across the system of who had what. And then again, that investment in inventory management, value analysis tools, that would have come in very handy at that time. But hey, at least it woke some folks up and gave us the opportunity to go start investing in it now. Everybody talks about the weather, but nobody does anything about it. A Mark Twain quote used by Carrier for quite some time, as you can imagine. So early action. So what this is a picture of is one of our classrooms upstairs. We basically, because most people, not all of us, were sent home, classrooms, conference rooms here within the hospital were vacated and turned into mini warehouses. So this is just a picture of the early stages of pushing some things out of the way. We had to centralize even within the hospital. We had to get PPE off the floors. We had to get it out of the receiving areas. Suddenly that stuff being stolen or going missing became a real risk. We had to put them in rooms that locked. We had to organize it. Now it didn't really matter to anybody if they got a yellow gown or a blue gown. They wanted to know it was an FDA approved gown that was safe to wear. And so we started building up inventory SKU by SKU, consolidating like things. Like we said with gloves, we got a couple different versions of gloves and you got sizes, but it didn't matter who the manufacturer was. You ordered gloves, you got gloves. So we had to develop some other alternative suppliers as well, get them vetted, make sure they're FDA approved, and start covering that gap between ourselves and what our distributor was able to provide. Again, it's throughout this, but buying in bulk. We had to develop ordering systems so the other hospitals could order from us. We didn't have anything for like an internal transfer. So that had to be created, and our IT people helped do that, mimicking what the lab ordering process has been. So we were stealing shamelessly from other success stories within the U of R system. Like I said, converting classrooms and conference rooms into distribution centers, organized by product. Then again, where we started getting some help. So our employee health folks, the N95s that nobody heard of 3 years ago, but you've all seen what those are. N95s traditionally were only used for tuberculosis patients. So how many of those did we ever have? So we didn't have a whole lot of those in stock when we started. And then to have the CDC or anybody else start recommending those for everybody really starts putting a drain on things. So we had to protect those. But we had folks come in and say, we can clean those for multiple uses. So a system was developed around that. Like I said, the shields, the hand sanitizers, very creative people finding new ways to provide the supply we needed. And then wonderful people who started donating things. We started, people would back up with trucks. I remember the Dental Society of Rochester, because a lot of that was shut down. They donated to us gowns and masks and shields, all the way down to, I hate to say it this way, a little old lady who pulled up one day with 3 masks that she donated. We took them and said, thank you. And then we would distribute those. Some could go to healthcare workers. Some we might send to other people who weren't patient facing. But again, a whole new process that had to be created on the fly. I see a couple things in the chat here. I'm going to look at real quickly to see if there's a question there that's.
Yeah, we do have a question, Tom, that came in
Okay.
our Q&A area.
Okay.
It is, how did the crisis introduce creativity and innovation surge across the teams? This person would like to hear the top 3 examples.
Okay, you know what? And I'll
You gonna go back?
No, but it's a good question. The funny thing is, and it's not a quote that I have on any of these slides, but my own boss, who's the COO here at Strong, she says a pandemic, don't waste a crisis. A pandemic's a great way to drive innovation. And these are some of the things short term that it drove. So I'd actually answer the question 2 different ways, both short term and long term. So I'll use this slide to illustrate some of the short term things. Like I said, people helping with the manufacture of certain things. And it went outside of here too, right? We had Ford donate, the Ford Motor Company donating shields. We had the bourbon manufacturer, Black Button Distilleries making hand sanitizer, which we were careful not to send to the nursing homes because they were in the same bottles. We don't want anybody being confused. But it did yield a whole lot of creativity and innovation, both from the product side. And actually, let me show you on the next slide is a really good illustration. But before I say that, I'll answer the long-term part of that a little later on. So we'll start with the short-term innovative things, and then we'll get to the long-term stuff a little later on. But a really good example here. So one morning, myself and the supply chain leader here at Strong, we attended this command center meeting every morning. And suddenly the requirement came from the governor's office, back when everybody thought he was a hero. But from the governor's office, that we were to report every day on this list of items, how much inventory we had, how much we were using every day, and then the math, how many days of supply did we have. So that requirement came, and we had no system for either one of those things. And so here we got innovative, right? So, her name's Katie. She's got a good, strong finance background, and she and her team broke off and found a way. And then there's a lot of physical things here to start counting what we had, but she put it into a really good spreadsheet that all of the hospitals could feed their daily inventory numbers into. And then it would roll up so we could report it as a system. Again, very manual, Excel, not elegant, but it was effective. And then everybody kind of estimated based on what they dispersed out, what their usage rate was. And from that, a little quick division, and we would estimate how many days of supply we had. And we were required to hold 90 days of supply, despite the fact that so much of the supply was being diverted away from us by the very government agency that told us we had to have 90 days, and also threatened to come and take some, to send the National Guard to pick up this and other things like ventilators and bring them down to New York City. Now, we weren't against that because they were way ahead of us in terms of spiking in New York City than when we started seeing bigger numbers. And we did provide various hospital systems and the county with supply when we could afford it. So obviously the concern here and the reach extended well beyond our system. But I remember one time Stony Brook Hospital and the Stony Brook Hospital system in Long Island was down to their last day on gowns, and we sent them like 30,000 of them to help them out. But again, massive problem. So I always loved, I don't know how many of you read the last lecture, but if you have to eat a frog, don't spend a lot of time thinking about it. Just if you have to eat 3, don't start with the smallest one. These were major problems, and we had to address them as they came. But again, from a systems perspective, this was about as innovative as it gets, right? We had no way to meet this state requirement until it was created internally, and we've continued to survive on that. Other interesting challenges. So with all the little old ladies and dentists and all the new suppliers we're finding, all the do-gooders of the world, came the others who were going to take this time to capitalize for themselves. So lots of counterfeit mask manufacturers, or stolen product. If they had it, they wanted to charge us 10 times what others were charging. Suddenly, what used to be a 4-cent mask is costing $1. So we had to go carefully through all of those. And then we got a call from the FBI one day asking about a particular supplier and posing as us. So now we were really getting into interesting times here. We actually gave an FBI agent an email address that looked like he was one of us, so they could go target a particular individual or group of individuals who were sending out false POs that looked like they were ours, actually had one of our buyers' name and number on it. I think they just got lucky because the one they chose was on long-term disability. So any calls to that number went unanswered. But they tracked him down, and there was an arrest made. And luckily we stumbled upon it because where they were having this product shipped was not one of our sites. And one of them popped up as Latham, New York, which is out by Albany. And that struck our supplier as odd. And so that was a whole thing. Lots of people promising that they had product, get a PO, then they don't. We didn't pay anybody in advance. We didn't pay anybody in Amazon gift cards, any of that stuff. We didn't fall into any of those traps, but all of that was at play as well. So we wanted to trust everybody. We just could not. And then again, one of my required reading books when I worked at GE was one of the many that Jack Welch put out, but Control Your Own Destiny or Somebody Else Will. So we had to set up, we had to become our own distribution center. So you can see the warehouse on the left. We had to push a whole lot of other things out of the way. Beds, stretchers, also which were in great demand. But we had to have a place now as we found new suppliers. You know, suddenly we found the challenge of, okay, now what do we do when 500,000 masks come in? Gowns, gloves, etc. So that warehouse was set up to serve all the external, by external I mean non-strong sites. And then here is our fitness center here in the U of R Medical Center here at Strong. And that turned into all the internal support. So you can see in pretty short order, the teams rallied, got it organized, got things labeled, developed ordering systems, and did a very, very good job of us never, even in the highest peak moments, we never had anybody run out of anything or have to resort to any extreme practices. So with that, I'll head into where we're heading for the future, unless there's any other questions other than the one I still owe a half an answer on.
No questions.
All right. So moving forward, today forward, where we really start with the creativity and the innovation and the question, right? Because we never want to live this again in our careers, right? So now, from a people standpoint, it's really opening up people to start thinking strategically. And again, that emphasis on the folks who are experts in supply chain within a hospital. How do operating rooms work? How do the various units work? And by the way, the answer to most of those things is there's no one answer. It varies by hospital unit, and it certainly varies by hospital. And it's different in a surgical center than it is here at the hospital, and it's different in a long-term care facility. But the people who really know what the greatest needs are, coupled with folks coming in from other industries with different experiences and knowledge, and putting all that together to really start a path on what are the skills we need to have. That's the top row. What are the systems we need to have? What are the operational processes and operations we need to put in place to get some consistency and reduce the variation and reduce the waste, right? All those things are coming into play, and it's all become part of a common language now here. And then how do we at the system level, the whole think globally, act locally thing is now, although we're not that global, we're all in New York State, but you know what I mean. From a process standpoint, we have invested in a warehouse. I don't know if any of you remember where Annixter Wire and Cable used to operate out of on Marway Circle in Gates, but we have leased that facility now, and we are starting to set that up as a centralized warehouse for a couple of different purposes, but primarily to serve the whole system in a distribution form. System level supply chain and value analysis resources. So every hospital has always kind of tried to figure out all these things themselves. One of the beautiful things about being in healthcare is I'm sure all of you have been on benchmarking trips or done different benchmarking type activities, and where you struggle is nobody produces the kinds of goods or provides the same kind of service that you do. And if they did, they'd be a competitor and you really can't go benchmark them. Here in healthcare, there are hundreds of hospital systems that have already solved these problems ahead of us, and they're not competitors, and we can ask and we can learn. So we are on a journey to do that as well. I already talked about the cross-functional collaboration and lean, and we've joined an aggregation group that's led by the Mayo Clinic in Rochester, Minnesota, and we've joined them to leverage spend and to pick up some operational efficiencies as well. And then on the technology side, we just really need an inventory system. And we are in a search for that right now with an RFP that's out and narrowed down to 2, so that we have a perpetual inventory system that's a little bit more alive than what we have today. Trying to get more into demand planning and anticipating what our needs are going to be, and more in terms of digitalization, automation, BI, all those things. Start managing by fact and data sets rather than hunches and emotions. So all of that is underway. A lot of skills have been acquired, and the folks that are here, giving them new access to training to further their development as well. So a lot of good things going on, a long way to go. So the future state, probably be repeating myself a little bit here, but to get an inventory system and start driving transparency. Some things that we may have assumed in previous lives that just don't exist here. And enabling communication, systems communication across all the hospitals. Well, we don't have anything in place now for somebody down at St. James Hospital to look to see if Strong has any excess. So rather than expediting out of their supplier, they could just do an internal transfer. That doesn't exist today, but we're getting there. The resiliency of our supply chain. So again, very dependent on a medical distributor that ran into their own problems. In fact, all the medical distributors did for a lot of obvious reasons, but to take control of our own destiny and have some alternative suppliers ready when we need them. Standardization also big here, just way too many SKUs for the same thing. So, all the benefits of that are clear. And then balancing standardization with diversity of our supplier base. All achievable. We just have to focus on it beyond what's ever been done before. And space. Of course, you could probably imagine what the cost of a square foot of space is in a hospital, especially a hospital like ours, which there's not a lot of room to grow. We can't grow to the west because there's a river there. We can't grow to the north because there's a cemetery there. We can't even grow that high because we're on the flight path to the airport. So floor space here is at a premium, and if it's chock full of boxes of masks, we're not using it to the best utilization that we can. So we go to an external warehouse. And instead of a stockpile of stuff waiting for a rainy day, that when by the time that day comes, it's all unusable, manage it as safety stock and put a rotation into it. Medical supplies expire. And so now we'll manage that better than we have in the past, so that we're rotating appropriately. And then what else can we do in that space to optimize it? So there's a whole lot of things here that extends well beyond the medical supplies that are of common usage across hospitals. Like I mentioned before, beds, stretchers, wheelchairs, all those kinds of things, ventilators in this case, respiratory kinds of things that could be shared across the system if only we knew how to manage it. So this will enable that. This is a rough graphical look at what that's going to look like. We expect to occupy it this early summer in June, and start operationalizing it. There's a lot of pieces that have to be designed and operationalized in order for that to happen within the warehouse, and also the transportation and logistics back into the medical center. So plenty of work to be done there. And then my last slide is a little dated because it goes back to September, but just pulling some of the lessons learned and looking ahead. I'm sure you're pretty familiar with all of these things because they've played out right in your hands. Still no idea when this might last, you know, how the shipping industry has been impeded, and even if we started feeling relief on that, now the truckers have things clogged up, you know, so not only the cost, but the throughput of all of it just keeps crimping tighter and tighter. So, and then the very last piece, and I'll put in a plug for my alma mater at RIT. We're going to really have to start looking at the folks coming out of these supply chain programs and growing from within, because filling supply chain positions is so difficult now if we don't actually start developing the skills and expertise we need for the future. I think we're gonna have a tough time acquiring it. And in healthcare, it's even, there's other reasons to make it more challenging. And for one, it just doesn't pay quite what most industry leaders would get paid. So it's time to develop our talent rather than try to acquire it each time. So that brings me to the end of the slides. I'm more than happy to open it up for dialogue, starting with asking whoever asked that question if I answered it sufficiently.
Okay, yep. Hold on. Okay, another question. Did your Lean Six Sigma background make a difference in how you approach supply chain crisis? If
Right,
so, how?
Okay.
I would think so, right?
I'm almost guessing who's asking some of these questions, but of course, yes, right? Of course, yes, right? So, I think the big thing too, and how, I mentioned, without mentioning Lean Six Sigma per se, that, it's all about reducing variability, right? That's the Six Sigma part, and reducing or eliminating waste, which is the lean part. Lean has been something taught and practiced here for a number of years, probably 6, 7, 8 years that's been introduced here. There's obviously a lot of things that, in terms of the flow of people and the flow of goods throughout a hospital, could always be improved. I think if you're looking for it or know what you're looking for, if you've been in a hospital or a doctor's office or a surgery center, in the last 5 years or so, you see different checklists, you see different things that are Lean Six Sigma tools. But I think the biggest thing here is that any Lean Six Sigma project starts with really clearly identifying the problem you're trying to solve and defining it well and understanding what data you have to measure and analyze. I think too often throughout this, people just try to jump to quick fix solutions, and they just didn't exist, right? But again, we got on this early. We understood what the problems were. We understood what the opportunities might be. We very methodically went through our steps to do that, implemented those solutions, and then made sure we controlled them on the back end. So those of you with a Lean Six Sigma mind know that I just walked you through DMAIC, right? Define, measure, analyze, improve, and control. And that rhythm played throughout, and it continues to drive us. We don't use the Lean Six Sigma vocabulary as much here because, well, it's not as pervasive here, and we don't want to scare people because it's not about for everybody doing intense data analytics, which can be scary, but it is about understanding when you have a problem or an opportunity in front of you and being able to define it well. And we've got a number of people here now within the supply chain family that can coach and help with that. So yes, that was a tremendous help.
You know, I did have a question for you myself. I know you were talking about the need for people in supply chain, you know, for the University of Rochester and the hospital system. What type of skill sets are you looking for these incoming supply chainers?
Yeah, okay, good. And I think you noticed the bio that went out. I am an example and an walking advertisement for getting cross-functional experience in your career, especially in this area, because it just helps. So, you know, we need people. I'll start on the purchasing side of things. We need people who can interpret, manage contracts, understand contract language. In fact, you said, and I don't know if he's joined us yet, but I know I brought a team out to one of the ISM meetings a couple of years ago where Jim Deasy walked through contract language. That's key, right? That's one of them. Negotiation skills, very, very key on the purchasing side. Data analytics everywhere, right? Whether it's pricing and purchasing, whether it's usage, whether it's quality, the data analytics, I mean, it's become pretty common and a lot easier lately to gather data. But if you need the people who can interpret it and tell stories with that data, right? It doesn't do me a whole lot of good to have my team send me massive pivot tables and the Excel spreadsheets themselves. I want to know what we've learned out of that and what direction it takes us. So data analytics is just huge. The knowledge of healthcare and the internal materials management, how an OR works, is valuable, but that can be learned here. All of it can be learned here. But it's a discipline of service, right? It's being proactive and reactive. It's being on call, right? You know, the folks that run the hospital never closes. We don't have a shutdown for 2 weeks in the summer or around the holidays. And you just don't know what the need might be and what crisis might come along. A particular surgery because of a particular event, a thing that lasts for 2 years. So people who are very flexible, and quite frankly, are used to working very hard. The lean or the Lean Six Sigma background and experience is very valuable. Just basic problem solving skills, very valuable. So there's technical stuff, engineering skills that help with that. There's systems. Boy, it's almost anything, because my job is to find folks with these diverse skills and get them working complementary with one another. We don't need, I wouldn't need a team of all folks who did data analytics. I wouldn't need a whole team of people who are good negotiators. We need a blend of all those things. So it's fun when we can take those and apply it all to an inventory strategy, or a demand planning strategy, or a warehousing strategy, or all the pieces that are part of an overall good supply chain strategy. Looking ahead, I mean, we're looking ahead 10 years now with where we want to be with this consolidated service center, a new ED tower construction project, which is going to change the flow of material inside of Strong. It's endless, because, like I said before, healthcare in general is relatively immature in the supply chain space.
Wow. Thank you very much. Wow.
And a great opportunity for somebody at any point in their supply chain career to come either lend that experience or to start to pick it up.
Oh, wonderful. Well, thanks for presenting this important topic tonight. If anybody does have a question or comment, just stick it in the chat, and and then we'll talk about it. But I thought the information was great. Especially the timeline and all the collaboration you were talking about. It's such a and I'm not in the medical field, so I have relatives that are nurses. So I sort of knew some of the background that they were going through, but to see it from your side and more administrative, it's a lot different. The challenge.
I should mention that the clinical side of this is a very key collaborator. The nurses, the surgeons, the physicians, they are a major part of us establishing strategies, because in the end, they're our customers. Something said to me when I was making the decision to come here that rings true pretty much every morning, that it gives you a whole lot more purpose in your career when you're getting up and knowing your goal today is patient care rather than shareholder value. And it does lend a lot more meaning that the products you're getting are to be used either by patients or the people that are caring for them. And again, I don't diminish what it means to not run out a manufacturing line. I've taken enough beatings for that in my career. This does just take on a little bit more of a value proposition for each of us personally.
Definitely. Well, thank you for sharing your thoughts. Actually, a nice thank you from Leanna. Thank you, Tom, from Leanna. And I want to thank everybody for joining us tonight. We did record this, so if anybody would like to share it with their colleagues, I'll send out the recording tomorrow to everybody. And everybody does get a continuing education point for this tonight as well, for those that are doing their certification. Another one, congratulations on driving the team to weather the COVID challenges.
Yeah, we're it's kind of one of those things where there are a lot of heroes that emerged everywhere, like in this pandemic, right? And certainly here, a lot of supply chain folks and groups were called out by management and recognized, and well deserved. And now our goal is, if this were to happen again, that it wouldn't require heroics. We've got the people process systems in place to be ready for the next one. So yeah, it's we learn, right? We learn with our experiences, and I don't think there's any industry, there's certainly no geographic region, there's nothing ever in our lifetime that has touched everybody like this has. But we want to get positives out of it, so that's our focus now. So anybody who wants to reach out, do so any way you can. Kathy, Leanna, I've got my contact information. Hit me on LinkedIn, do whatever you want to do. And if we've given you some thought on wanting to join us, we constantly have opportunities around here, and maybe we can make that kind of a fit too.
Oh, that's fantastic. See, glad everybody joined us tonight. See, there are some opportunities within this hospital with system, which is great, This is what we're all about tonight.
Yeah.
So again, I would like to, I'm going to close out the segment for tonight. Thank you all for joining us, and thank you for a great presentation, Tom. And question, if anybody wants the slides, could you share them with me? And then I'll send them out to everybody. Are you able to or not?
Sure. Yeah, I'm just trying to think. There's nothing in here that's confidential. So yes, I will send it to you. And yeah, feel free to share with anybody who requests them.
Oh, thank you so much. Okay, saying yes, please share the slides. So, okay, so thank you, Tom. Thank you to all of our participants tonight, and have a great evening. Just want to say one thing, March 9th will be our next Lunch and Learn webinar, and I'll be sending information out on that within the next week or so. Okay, everybody have a great evening, and thank you all.
All right, thanks for the opportunity, Kathy.
Oh,
Leanna?
thank you.
All right, bye-bye.
Bye.